You can this if you do that, then full screen. Yes.
Hello.
Good morning, sir.
Good afternoon.
Good afternoon, sir.
Thank you. Okay, shall we start?
Yes, sir. Yes, sir.
Yeah, in the last class, the last few minutes, the internet was not functioning. As a result, we all of a sudden stopped that. Okay. Yesterday, we were talking about general toxicities of anti-cancer drugs. Am I right?
Yes, sir.
Okay.
Yes, sir.
Now, the gonads, since gonads are also having rapidly multiplying cells, so there is inhibition in the males, impotence and oligozoospermia. In the females, inhibition of ovulation and amenorrhea. It will damage the germinal cells, which will result in mutagenesis. That means abnormal formation of the fetus. So they are called mutagenic drugs. Now, for example, if they are used for a pregnant woman, it will have its influence on the fetus. It will damage the developing fetus. Depending upon the time of gestation, there may be abortion, fetal death, or teratogenic. The child may be born with some defects, inborn defects. That is called teratogenic. Next is carcinogenicity. What do you mean by that? You are treating the cancer. Can you see the slides?
Yes, sir.
Okay. So your aim is to treat the cancer. Then how is that carcinogenicity? No doubt you are treating the cancer, but these drugs can cause some other cancers in some other organs. So that's why we call this as a secondary cancer, like leukemias, lymphomas, histiocytic tumors. They may appear many years after the use of cytotoxic drugs. So why? This is due to the blocking of cell-mediated and humoral factors. Because of that, after many years, after stopping the drug, there may be appearance of some different cancers. So they are called secondary cancers. So these drugs are cancerogenic in nature. Then hyperuricemia. You know, these cells, these drugs, they are cytotoxic. They will kill the cells. So there is massive cell destruction. And as a result, the product of cell destruction, they cause hyperuricemia. So this hyperuricemia is secondary to massive cell destruction. Then what is the end result of this hyperuricemia? Acute renal failure, gout, and urate stones, uric acid crystals, they may be deposited in the urinary tract. These are all the consequences of hyperuricemia. Now to prevent this, we can give allopurinol. Allopurinol is protective by decreasing the uric acid synthesis. Now these are all the generalized toxicities. By and large, all these anti-cancer drugs, they produces these toxicities. However, in addition to these, there are certain drugs, individual drugs, they may produce specific adverse drug reaction in addition to these generalized, they may give rise to specific adverse drug reaction. Few examples. Vincristine is an vinca alkaloids. Vincristine, they can produce neuropathy. An antibiotic, doxorubicin, it may produce cardiomyopathy. Cyclophosphamide, it can produce alopecia and cystitis, inflammation of the bladder. What has happened? Dr. Damodar? Dr. Damodar? Dr. Damodar? Can you see the slides?
Yes, sir.
There was some technical problem. So these are, in addition to generalized toxicity, these are some drugs having specific toxicity. Now, after knowing the toxicities, how are you going to minimize these toxicities? What is called as toxicity amelioration. You know very well, these drugs will produce toxic reactions, but how to minimize this? Now, why these toxicities? Because as it is, the drugs are toxic. Second thing is, to kill the maximum cells, you are giving at the maximum tolerable dose, high dose and intensive regimen. That's why the toxicity is much more. So how to minimize these toxicities? You can minimize by giving number one, toxicity blocking drugs. Drugs which can prevent this toxicity. Now, for example, methotrexate is one drug. It is mechanism of action is folic. It reduces the folic acid synthesis. It blocks. So as a result, there is toxic reactions. You can prevent that by giving folinic acid. It's called folinic acid rescue. You are rescuing the methotrexate toxicity. Even if you increase the dose of methotrexate to the fold of 100 times, folinic acid will prevent the occurrence of toxicity. Similarly, cyclophosphamide is another drug. When this drug is excreted through the urinary system, it causes inflammation of the urinary bladder, what is called as cystitis. Cyclophosphamide and ifosfamide. So how you can prevent that? So that cystitis can be blocked by giving systemically a drug called mesna. So systemic administration of mesna and irrigating the bladder with acetylcysteine. You wash the bladder with acetylcysteine. By doing so, you can prevent cystitis. Now, yesterday we have seen that cytotoxic drugs, they stimulate chemoreceptor trigger zone. What will happen as a result? There is vomiting. And that vomiting can be blocked only by ondansetron, not by the other anti-emetic drugs. Ondansetron, it will block or it will prevent the cytotoxic drug induced vomiting. Now doxorubicin, it causes cardiotoxicity. It is an antibiotic. It is used for treatment for cancer. It causes cardiotoxicity. This can be controlled by prior intravenous infusion of dextrazocaine. What is nothing but an iron chelating agent. Dextrazocaine. If you prior administration, IV infusion of this drug, it will prevent the cardiotoxicity produced by doxorubicin. Then cancer chemotherapy in general and radiotherapy in particular, they causes cytotoxic, you know already. So this cytoprotective, you can protect the normal cells. How? By giving amifostine. It will protect the cells against the cancer chemotherapy and radiotherapy. Then hyperuricemia. You already just now you have heard that can be reduced by giving allopurinol and also alkalinization of the urine and plenty of fluids, so that you are not allowing the uric acid crystals to deposit and causes crystalluria. So lot of fluids and all kinds of urine, and along with the oral administration of allopurinol, it will prevent the adverse effects of hyperuricemia. Then hypercalcemia. Hypercalcemia is a complication in certain cancers like myeloma, breast and prostate cancer. So this hypercalcemia can be treated by vigorous hydration and bisphosphonates. Now, the another way of preventing toxic reactions is by giving the drugs in pulses. What is that pulses? You are giving one course of treatment. You will give a gap of 2 to 3 weeks. Then afterwards, you are giving another course. A pulses, depending upon the severity of the disease, 3 pulse or 4 or 5, etc. So one dose is given for 3 or 5 days, whatever may be, that is the one course. It will be given drug holiday for 2 to 3 weeks. Why this interval? This interval is necessary for the recovery of the normal cells. Just like the cancer cell, normal cells also dying, they are killed. And that causes severe reactions like coagulation, coagulatory failure, then secondary infections, etc. So in order to prevent that, to minimize these toxic effects, you are giving 2 to 3 weeks of interval to allow the normal cells to recover. Then another way to protect is selective let us say, instead of giving a drug intravenously or orally, you can give this drug by intra-arterial infusion to the limb in that area, wherever, that means whatever the artery which is feeding that tumor, to that artery you are injecting the drug intra-arterial. That means the maximum drugs will go to that area only. So intra-arterial infusion, particularly the tumors in the limb, upper or lower limb, head and neck. Or you can give intrapleural or intraperitoneal. Now, for example, the lung cancer, there will be pleural effusion, then abdominal ascites. So to treat that, you can give the drug into the pleural cavity or into the peritoneal cavity. That means you are not exposing the other cells. You are maximum exposing the diseased cells. Then there are certain drugs which can be given topically. That means locally, local application on the lesion, wherever there is a lesion. If there are isolated lesions, for example, skin, buccal or vaginal mucosa, in such cases, you are applying only to that affected part. That is called topical application. That will reduce the systemic toxicity. Next, you know that granulocytes, there will be agranulocytosis, then platelets, they are affected because by bone marrow depression. That can be given by way of transfusion. Why you have to give that? Otherwise, platelet count is very less. It can cause bleeding. Granulocyte, less number. Person is, the defense mechanism is not there. So subject for infection. To prevent that, to prevent bleeding and infection, which are the adverse effects of systemically used anti-cancer drugs, that can be prevented by giving blood transfusion. Now, in addition to that, there are certain biological agents like recombinant growth factors, etc. By giving that, you are hastening the recovery from drug-induced myelosuppression. Then interleukin-2, it is a cytokine, has anti-tumor property. So these are called biological agents which will hasten the recovery or which will have preventive, which will have particularly anti-tumor activity like interleukins. Now, if there is aplastic anemia, the bone marrow is totally blocked. Now we have to give bone marrow transplant. After treatment with high dose of myelosuppression, so you have to treat the patient with bone transplantation. The next drug is called thalidomide. Thalidomide, earlier it was used and in the 1960s it was blocked because of teratogenicity. It was stopped. Now again it has started using. It is used as an adjuvant drug, particularly in erythema nodosum leprosum. That is the one type of cancerous tissue, and for that you are using thalidomide or to prevent the erythema formation in the use of anti-cancer drugs. And it has got anxiolytic, antiemetic and adjuvant anti-analgesic, analgesic property also. So that can be used. So these are the some of the measures you can take to minimize the adverse drug effects. So what are the probable questions that I have already uploaded the slides? You can go through it and try to answer them. After knowing these generalized features, now we'll go for anti-cancer drugs proper. Just like any other drugs, we are starting with classification. So these anti-cancer drugs, they are broadly classified into three categories. See, anti-cancer, any drug which can be used against the cancer. Broadly, how they are classified? Number one, cytotoxic drugs. That means those drugs which are capable of killing, destroying the cells. So they are called cytotoxic. They are toxic to the cells. They interfere with the mitosis, block, etc. So as a result, new generation will not be there, and whatever the cells are there, they are destroyed. So that group of drugs, they are called cytotoxic drugs. Second group of drugs, targeted drugs. Yesterday we have learned that in recent innovations, they are identifying the targets, anti-tumor targets, etc. So the drugs acting on specific targets so that the cancer cells will not progress. And number three, or third group, hormonal drugs. Because some of these tumors or cancers, they are hormone dependent. For example, carcinoma breast, carcinoma ovary, carcinoma uterus, carcinoma testis, prostate, etc. They are hormone dependent tumors. So to prevent them or to cure them, the opposite hormones are used. So those drugs which are got hormone in nature are like hormones, and they can be used, and those drugs, they are called hormonal drugs. Now let us study one by one what are subdivisions in that. For example, we are talking about cytotoxic drugs. The cells, the drugs which are toxic to the cells. They are further classified depending upon either their chemical nature or their pharmacological effect. So there are 7 groups. One is alkylating agents. Second group, platinum coordination complexes. Third one, antimetabolites. Fourth one, microtubule damaging agents. Fifth one, topoisomerase 1 and 2 inhibitors. Sixth group, antibiotics. And seventh, miscellaneous group does not belong to any of these groups. And all of them, they are called cytotoxic drugs. So cytotoxic drugs are classified as alkylating agents, platinum coordinate complexes, antimetabolites, microtubule damaging agents, topoisomerases 1 and 2 inhibitors, antibiotics, miscellaneous drugs. Next is targeted drugs. BCR, ABL tyrosine kinase inhibitors, EGF or HER receptor inhibitors, then the angiogenesis inhibitors, proteasome inhibitors, CD20 inhibitors. So these are the different targets, and different drugs will have they will make these, any one of these as their targets. Hormonal drugs, glucocorticosteroids, estrogens, SERMs, selective estrogen receptor modifiers, then SER, selective estrogen receptor downregulators, aromatase inhibitors, antiandrogens, 5-alpha reductase inhibitors, then GnRH analog, progestins, etc. These are all hormonal drugs. Now we are coming to individual drugs. So you have already seen that cytotoxic drugs, it has got alkylating agents, platinum coordinated complexes, antimetabolites, then other groups. So alkylating agents, they are further classified into nitrogen mustard, example cyclophosphamide, isophosphamide, chlorambucil, etc., melphalan, ethylamine, and thiotepa, nitrosurias, carmustine, alkyl sulfonate. So depending upon their nature, they are classified. Among platinum coordinates, cisplantin, carbaplantin, etc. Antimetabolites, folate antagonist, purine antagonist, and pyrimidine antagonist. Folate antagonist, methotrexate. Purine antagonist, 6-mercaptopurine. Pyrimidine, 5-fluorouracil. So only way to remember these drugs is you have to get them by heart. Then again, cytotoxic drugs, microtubule damaging agents, vinca-alkaloids, vincristine, vinblastine, taxanes. Then topoisomerase 2 inhibitors, etoposide, 1 inhibitor, topotecan. Antibiotics, actinomycin D, doxorubicin, daunorubicin, etc. Miscellaneous drugs, hydroxyureas, then L-asparginase, arsenic, trioxide, etc. So all these, they belongs to cytotoxic category. Now coming to targets, BCR, ABL, tyrosine kinase inhibitors, imatinib, dasatinib, then EGF or HER receptor antagonist, inhibitors, gefitinib, etc. Angiogenesis inhibitors, sunitinib, etc. Proteasome inhibitors, bardexobim, CD20 inhibitor, rituximab. Hormonal drugs, glucocorticoids, prednisone, SERM, selective estrogen receptor modulators, tamoxifen, aromatase inhibitors, letrozole, 5-alpha reductase inhibitors, finasteride, dutasteride, progestins, hydroxyprogesterone, estrogens, ethyl estradiol, selective estrogen receptor downregulator, fulvestrant, anti-androgens, flutamide, GnRH analog. So these are the different drugs. Now coming to individual groups, their mechanism of action, uses, and any adverse reactions peculiar to it. Now these alkylating agents, what all earlier you have seen those drugs, they are cell cycle non-specific. That means they will kill dividing and also a resting cell. Cell cycle non-specific. How they kill that cell? These drugs, they produce highly reactive carbonium ion intermediates. Highly reactive carbonium ion intermediates. Transfer alkyl groups to cellular macromolecules. Alkyl groups, they are transferred into cellular macromolecules, various proteins of the cells. That's why they are called alkylating agents. And they form a covalent bond, very adherent to that. As a result, the DNA precursor, what is called guanine residue, it is more susceptible. As a result, there is no synthesis of nucleic acid. So these drugs, they may also react with carboxyl, hydroxyl, amino, sulfhydryl, and phosphate groups of biomacromolecules. They not only act on carbonium, they can also act on carboxyl, hydroxyl and other macromolecules. Now, when once this alkylation, what is that alkylation? Combining these alkyl groups with that cellular macromolecules. That results in cross-linking or abnormal base pairing in the DNA strand. And the DNA cannot perform its function. Nuclear synthesis is affected. Hence, they have got cytotoxic and radiomimetic action. That means, just like X-rays, it causes radiation, ionizing radiation. That itself can kill the cells. That is their mechanism of action. Now coming to individual drug, cyclophosphamide. We are not studying all the drugs, very few very commonly used drugs. One is, such a drug is cyclophosphamide. The drug is inactive, that means it is a prodrug, converted to active metabolite in the liver. In addition to alkylating agents, cytotoxic activity, it has got immunosuppressant property also. It suppresses immunity. And these drugs, the cyclophosphamide is used mainly in solid tumors. Alopecia and hemorrhagic cystitis, they are very prominent, and you have already known that by giving mesna, you are preventing cystitis. Then chloramphenicol retards the metabolism of cyclophosphamide. The drug interaction, chloramphenicol is an antibiotic. It will retard the metabolism of cyclophosphamide, so it can reduce the toxicity. How to prevent cystitis? Mesna is routinely given systemically. It will bind and inactivate the vesicotoxic metabolite of isophosphamide and cyclophosphamide. Then, in addition, you are giving hydration, cystitis, that washing, lavage. Next is busulfan. This is specifically used for myeloid elements. That means lymphatic cells. Drug of choice in chronic myeloid leukemia, what is called as CML, chronic myeloid leukemia, busulfan. Adverse reaction, hyperuricemia, pulmonary fibrosis and skin pigmentation. Chlorambucil, it is a slow acting alkylating agent. It is active on lymphoid tissue. Drug of choice for long-term maintenance therapy of chronic lymphatic leukemia, non-Hodgkin's lymphomas and other few solid tumors. The other drug, melphalan, used in multiple myeloma and advanced ovarian cancer. Adverse drug reaction, bone marrow depression. Coming to nitrosurias, these drugs are highly lipid soluble. When the drug is highly lipid soluble, chances of them they are entering into the CNS. So they crosses the blood-brain barrier because they are highly lipid soluble. So they are effective in meningeal leukemias and brain cancers. Nitrosurias. Adverse reaction, nausea, vomiting. They are very common. And CNS effects because these drugs are crossing the blood-brain barrier, entering the CNS. Bone marrow depression is delayed because it's more soluble, lipid soluble, it goes to the other tissues. Example of that, dacarbazine. It is used in malignant melanoma, nausea, vomiting, flu-like syndrome, neuropathy and myelosuppression. Platinum coordination complexes. Cisplantin is the example. They are hydrolyzed intracellularly. So when the drug enters into the cell, they hydrolyze. They produce highly reactive substance which causes cross-linking to the DNA. So the effect is resembling to those of alkylating agents and radiation. That is slicing off the DNA, ionic radiation. It will not enter into CNS. It is not lipid soluble. Copper transporters, that is CTR1, involved in the entry of platinum complex into tumor cells. That means this is another way of targeting. You can primarily treat with the copper transporter. This acts as a vehicle to carry this drug into the particular tumor. This is called drug targeting. Uses metastatic testicular and ovarian carcinoma and other solid tumors like lung, bladder, esophagus, gastric, head and neck carcinomas. Now this drug is administered by slow IV infusion because it is highly emetic, and antiemetics are routinely administered before the infusion. Adverse drug reaction, renal toxicity, then tinnitus, deafness, sensory neuropathy and others. Carboplatin, this is better than cisplantin, low nephrotoxicity, mild and delayed nausea and vomiting. Dose limiting toxicity, that is thrombocytopenia. Uses ovarian carcinoma, which is of epithelial origin, squamous carcinoma of head and neck, breast cancers. Now coming to anti-metabolites. Now these are analogs related to the normal components of DNA or the coenzymes involved in the nucleic acid synthesis. So these drugs, they are similar in structure, which are called analogs, which are these components which are necessary for a nucleic acid synthesis, DNA or the coenzymes. They are analog. What will happen? Since they appear similarly, they competitively inhibit the utilization of the normal substrate. Instead of the cell, instead of using this normal substrate, these drugs are get themselves incorporated into the DNA, in the formation of DNA, and they form dysfunctional macromolecules. The cell which is so formed, it is dysfunctional. That means it cannot survive. That will be automatically dead. So in that, folate antagonist, methotrexate, this is folic acid analog. This is cell specific action, cell cycle specific, kills cells in S phase, that means synthetic phase, the phase where the DNA and RNA is synthesized. What is the mechanism of action? They act by inhibiting dihydrofolate reductase, blocking the conversion of dihydrofolic acid to tetrahydrofolic acid. This tetrahydrofolic acid is essential coenzyme required for one carbon transfer reaction in de novo purine synthesis. So now purine synthesis is defective. So utilizing this folate carrier, it enters to the cell, converts to active form. It also inhibits the thymidylate synthesis. So folic acid and thymidylate is not available. So what is the major toxicity? Bone marrow depression, megaloblastic anemia and pancytopenia. Then mucositis. What is that? Mucosal inflammation, oral gastrointestinal, leading to diarrhea. Now this drug is given orally Then drug interaction, salicylates, sulfonamides, dicumarol replaces it from protein binding sites. Aspirin and sulfonamides enhances toxicity of methotrexate by decreasing its renal tubular secretion. Antidote, how to prevent this methotrexate toxicity? Folinic acid, 15 to 30 milligram per day for 5 days orally, or 20 to 40 milligrams per meter square of body surface area, intramuscular or intravenous, or twice a day. Uses choriocarcinoma. It is also used for remission, acute leukemias. Earlier, the drug of choice cyclophosphamide bisulfan. After that, you give this drug to maintain remission, free from the disease for some time. Non-Hodgkin's lymphoma, breast, bladder, head and neck cancer, osteogenic carcinoma. It has got immunosuppressant property. So it is used in rheumatoid arthritis, what are called as autoimmune diseases, psoriasis and many other autoimmune diseases. Purine antagonist, 6-mercaptopurine, abbreviated 6-MP, and thiogonine. There is a spelling mistake. Double T is there. The mechanism of action, it inhibits the conversion of inosine monophosphate to adenine and guanine nucleosides, which are the building blocks for RNA and DNA. It will block RNA and DNA synthesis. What are the uses? Childhood leukemias, childhood acute leukemia, CAL, carcinoma and some other tumors. The drug is given orally, oxidized by xanthine oxidase, bone marrow depression, nausea, vomiting, reversible jaundice, hyperuricemia. These are the adverse effects. Azathioprine acts by getting converted into 6-mercaptopurine. This is a prodrug used as immunosuppressants in autoimmune diseases and organ transplant. Fludarabine used same mechanism of action, chronic lymphoid leukemia and non-Hodgkin's lymphomas. Adverse reaction, chill, fever, myalgia, vomiting, myelosuppression, opportunistic infections, etc. Pyrimidine antagonist, example 5-fluorouracil. They are these drugs use a broad spectrum, we say anti-neoplastic, that is anti-cancerous, antifungal and anti-psoriatic. This 5-fluorouracil converted in the body to the corresponding nucleotide, which forms a covalent ternary complex with methyl THFA and thymidylate synthesis, ultimately resulting in irreversible inhibition of thymidylate synthesis. So conversion of deoxyuridic acid to deoxythymidylate acid is blocked. There is failure of DNA synthesis occur due to non-availability of thymidylate. This will be 5-fluorouracil is incorporated into the RNA, interfere with RNA synthesis and function. So both the DNA and RNA cannot synthesize, interfere with the function. Hence it is acting as cytotoxic. Cisplantin, they become synergic with 5-fluorouracil. Uses solid malignancies of the stomach, colon, rectum, pancreas, etc. Adverse reaction, bone marrow depression in GIT, mucositis, diarrhea, nausea, vomiting, peripheral neuritis addition. Microtubule damaging agents, vincristine and vinblastine, they are the vinca alkaloids. They are mitotic inhibitory. That means they are acting at the mitotic stage. They block the mitosis. How? They bind to microtubular protein, what is called as tubulin. Prevents its polymerization and assembly of microtubules, causing disruption of that is mitotic spindle and interfere with cytoskeletal function. The final result is metaphase arrest will occur. Cells will not pulled up to the terminal ends to form two nuclei, two cells. So chromosomes fails to move apart during the mitosis. Therefore, they are cell cycle specific because they act at the mitotic phase. Uses childhood acute lymphatic leukemia, acute myeloid leukemia, Hodgkin's disease, Wilms tumor, Ewing's sarcoma, lung cancer, etc. Adverse reaction, peripheral neuritis, alopecia, ataxia, nerve palsy, autonomic dysfunction, bone marrow depression. Taxanes, example, paclitaxel, cytotoxic. It will interfere with the tubulin microtubule dynamics. Uses metastatic breast carcinoma, ovarian carcinoma. Adverse reaction, neutropenia, arrhythmias, fluid retention, etc. Topoisomerases 2 inhibitors, etoposide, arrest cells in G2 phase. That means first generation, which goes to the next generation multiplication, it will arrest because there is a DNA break. Uses testicular tumor, lung cancer, Hodgkin's lymphoma, CA bladder, stomach. Adverse reaction, alopecia, leukopenia, J disturbances. Topoisomerase 1 inhibitor interferes with topoisomerase 1, damages DNA, acts in the synthetic phase, arrests cell cycle at S2 phase. Uses cervical cancer, small cell carcinoma. Adverse reaction, bone marrow depression. Antibiotics, they interact with the DNA strands and interfere with its template function. Example, actinomycin D, used in Wilms tumor, rhabdomyosarcoma, Ewing's sarcoma, choriocarcinoma. Adverse reactions, vomiting, then diarrhea, alopecia, steatitis. Daunorubicin and doxorubicin, commonly used in acute myeloid leukemia, acute lymphatic leukemia, solid tumors of breast, thyroid, ovary. It is a cardiotoxic, bone marrow depression, alopecia and stomatitis are the adverse reactions. Then we will stop at this stage and continue in our next class.